Good morning, everyone, and welcome to our Tyro multidisciplinary seminars. For those of you who are joining us for the first time, we have a really wonderful program this morning. It is a pleasure for me to introduce two members of the medical board of Tyro, who have both appeared many times on the Tyro Friday morning platform. First of all, Dr. Eyal Robenshtok, who is presenting this morning, is an endocrinologist who specializes in thyroid cancer. He heads up the thyroid cancer service at the Davidoff Cancer Center in Tel Aviv. After completing medical school and specialty training at the Rabin Medical Center, he traveled to New York to complete fellowship training at Memorial Sloan Kettering Cancer Center, where I must say he came under the evil influence of Dr. Tuttle and Dr. Shaha. Dr. Robenstock's research focuses on individualized risk-stratified thyroid cancer management. He is widely published and decorated for his contributions to thyroid cancer management. And I'm joined this morning as a discussion by Dr. Ashok Shaha, who's a head and neck surgical oncologist who has been at Memorial Sloan Kettering since before I was born in 1993. He has had a remarkable career as a surgeon, an academician, a teacher, and a mentor. He is widely renowned and highly decorated for his contributions to our field. His 997 publications serves as a remarkable achievement. And I personally, in my friendship to Ashok, have taken upon myself to try to push him over the 1,000 publication milestone. I personally have 2,000, but I wanted him to at least get to 1,000. And so we have jointly published, or soon to be published, a joint manuscript on invasive thyroid cancer that will be coming out shortly. But I'd like to demonstrate my role in Ashok's reaching the 1,000 milestone. And so for all of you who are fans of American football, the Eagles, which are shown in green on the left here side, have a very famous play that's known as the tush push, or as otherwise known as the brotherly shove. And if you could just roll the video there.
Yeah.
So the quarterback.
There he goes. Getting there we go.
There you go. So I'm the guy who's pushing Ashok over the goal line to get to that 1,000 publication mark. So with that, you can stop that. I just want to welcome both of my colleagues and friends to Tyro this morning and thank them as always for contributing their knowledge and their wisdom. I just want to take the opportunity for a moment and just highlight our voices of wisdom, and for all of our listeners, keep an eye out for Thursdays, the third Thursday of every month, when the podcast will be released. We have a great lineup that is being moderated by Dana Hartle. She's done a spectacular job, and everyone, I'm sure you will enjoy these. Actually, I made a mistake. It's the third Tuesday, not the third Thursday. So with that, Eyal, I'm going to turn over the program to you, and look forward to your wisdom and your experience here.
Okay, thank you, Mark. And that was the best introduction, I think, ever of the Thyro sessions. And thank you for the invitation. And it's a privilege to present this topic with Dr. Ashok and Dr. Urken, who were pioneers in this field and were some of the first to integrate new approaches in thyroid cancer. So today, the topic we're going to discuss is thyroid lobectomy, and the headline is navigating thyroid lobectomy, because we have so many questions and so many decisions to make when treating patients who undergo lobectomy, and hopefully till the end of the hour, we'll have lots of answers to the questions that we have. So it all started, as we know, in 2015. Until then, the recommendation was to do total thyroidectomy for all thyroid cancer above 1 centimeter, we'll touch on that study that was the basis for this recommendation. But in 2015, the gates were open to do lobectomy up to 4 centimeters, and we had a new approach, but many new questions. So when do we do active surveillance and when lobectomy? When do we do completion thyroidectomy? And so specifically, what do we do with multifocality, with minimal extrathyroidal extension, with torsal variant? What is the thyroglobulin levels that should we expect after lobectomy? And what's the TSH target? So these are some of the questions. We have even more. And since then, since 2015 and until today, there were many great studies, and we have answers, pretty good answers for many of these questions. So first, what we're going to discuss today is based on the approach to paper we just published in the JCM together with my colleagues, Gidi Bachar and Amit Ritter, and it includes many of the studies from Memorial Sloan Kettering, from Mount Sinai, and many other centers around the world. So let's start with the big picture. We know that in the population, there's a large reservoir of indolent thyroid cancers. And autopsies, this is one of the largest studies. In autopsies, we find thyroid cancer in people who were without thyroid cancer during their lifetimes. Between 4% and 11% on autopsy after their demise were found to have post-thyroid cancer. We actually diagnosed only 0.3% of the US population. So for every 1 patient we diagnose, there are about 20 patients. We estimate the real number is around 6%. So 20 patients undiagnosed for each one that we do diagnose. And the US Preventive Task Force, based on the data from Korea that showed that if you screen patients and you treat many, many small PTCs, you don't improve the outcome of the patient, recommend against screening for thyroid cancer. So we know there are many people, these are not patients, there are many people with thyroid cancer, and we don't screen for them, and we sleep soundly at night knowing that they exist because they're going to be fine. Now, in real life, this was theoretical. In real life, we have a population of people, and let's say 1 patient, she had GE reflux and some uncomfortable sensations in the neck. She had a neck ultrasound, and we find what looks like an apparently low-risk thyroid cancer. We know, according to this big picture, that for most patients, most patients need nothing. Most patients don't need treatment at all. But if we do send them for lobectomy, for the vast majority of patients, it would be more than enough. Not just enough, but more than enough. And we'll come back to that point later in the talk. So what are the advantages of lobectomy? Why is it better to have a lobectomy rather than total thyroidectomy? So obviously less hypothyroidism. And we know that with hypothyroidism, most patients feel okay, but there is a slight decrease in quality of life. We'll touch upon it a bit later. And it's because of the treatment, the hypothyroidism and the treatment. And if we set the goal for treatment, like in the ATA guidelines of TSH below 2, most patients will require therapy. And if the goal is normal TSH, only 30% will require therapy. So we'll discuss later, but I can also already say that the goal that we use today for patients under lobectomy, low-risk patients, is TSH within the normal range. That means that when we refer patients for lobectomy, most of them will not require treatment for hypothyroidism after surgery. And these are the risk factors: a higher TSH, female, Hashimoto's thyroiditis. That makes sense. Another very important consideration when thinking of lobectomy versus total thyroidectomy is the complication rate. So this is a pretty recent meta-analysis There were some in meetings, some people would say there's not a significant difference in complication rates between lobectomy and total thyroidectomy. Well, it doesn't make sense because it's half the surgery. We don't see permanent hypoparathyroidism, and also the risk for vocal cord paralysis. We have one cord in jeopardy instead of two cords in jeopardy. And that all leads to better quality of life. So again, a meta-analysis, again, pretty recent, 25 studies, and they showed that patients with total thyroidectomy have more impairment in physical and social quality of life. These are all questionnaires. And for us, for physicians who treat thyroid cancer, most patients do well, but we do see these patients that don't feel as well as they did before total thyroidectomy. And recent studies showed that most or a large part of this decreased quality of life is correlated with hypothyroidism and LT4 levothyroxine therapy. That means that if we have patients who undergo lobectomy and have hypothyroidism after surgery requiring treatment, their quality of life is going to be the same, more or less, as patients who undergo total thyroidectomy. But patients who have lobectomy and have normal thyroid functions after surgery will have a excellent quality of life like the general population. And of course, these few patients who have serious complications like hypoparathyroidism or vocal cord paralysis are going to have decreased quality of life. So it really makes sense that if you can effectively treat thyroid cancer with lobectomy rather than total thyroidectomy, it really makes sense to choose lobectomy. Now, the next question is, okay, is lobectomy effective enough? Okay, we know that it's going to be better quality of life, less complications, but we need to treat and cure the cancer. And we'll start with one of the most famous, not in a good way, studies. This is a study by Billy Moria from 2007. They looked at the NCDB database, 52,000 patients, and they showed that patients with PTC larger than 1 centimeter, if they undergo lobectomy, have higher mortality rate compared with total thyroidectomy. And this was one of the biggest reasons that in the 2009 guidelines, the recommendation was total thyroidectomy for lesions larger than 1 centimeter. But there were a lot of criticism of this study. There was not enough control for patients' characteristics and for tumor characteristics. So in 2014, the group by Julian Sosa did the same study, you can say. They looked at the same database, more patients this time, with adjustment for comorbidity that may lead to mortality and for tumor characteristics, and found no difference between lobectomy and total thyroidectomy in low-risk disease. And that was one of the important papers that led the 2015 guidelines to open the gate for lobectomy for a large population. Since then, there were multiple studies and meta-analysis that shows that in low-risk patients, there was no difference in recurrence, overall survival, or disease-specific survival with lobectomy or total thyroidectomy. So lobectomy is safe, a safe treatment for cancer in low-risk patients. The next question is what happens in intermediate risk patients. And this is from the ATA meeting, a poster from the ATA meeting. Dr. Camilo Gonzalez and friends, and Mark Urken is the last author. And they did a meta-analysis about intermediate risk patients, whether lobectomy is sufficient, 10 studies, and the outcome was there is no evidence for better survival or recurrence. And in the next guidelines, they're gonna look at intermediate risk patients as two groups. One is low intermediate and the other is intermediate high. So we're talking about the low intermediate group, and we're gonna define them better in the next slides. So we're pushing the boundaries of patients who can have lobectomy, not just the very low risk patients, but also into the low intermediate group of patients. So if lobectomy is the same as total thyroidectomy, and a patient comes to see us and asks, okay, I'm going to have a lobectomy, what is the risk of recurrence, and what is the risk I will require a completion thyroidectomy? So we need to have the numbers. It's not enough to tell them, well, it's going to be the same as total thyroidectomy. They need a number for us to counsel them about the risk of recurrence. And this is not such an easy number to come up with because it depends on many factors. Let's say you don't have a quality ultrasound before surgery. The risk of recurrence is going to be higher because you're going to miss a small lymph node or minimal extrathyroidal extension or other risk factors. Or if you look at younger age population rather than older age population, the risk of recurrence will be different. So far, there were 4 meta-analyses, all published in 2020, and they included different studies. The first 2 included mostly low-risk patients, and the 2 below also included patients with higher risk disease. There are some studies about lobectomy for high-risk patients with lymph node metastasis, with gross extrathyroidal extension. We shouldn't look at these numbers. We should look at the patients with low risk. So first, you can see there's no difference between lobectomy and total thyroidectomy, and the number that we usually use is around 5%. Why? We look at studies, including low-risk patients with low rates of completion thyroidectomy. Why is that? Let's say someone had a lobectomy, and in the pathology report, all patients who have minimal extrathyroidal extension have completion thyroidectomy, and on the other side, you find a 2 millimeter PTC. Some studies will call it recurrence or persistence, or would put them in an adverse outcome group, where in fact it's probably has minimal clinical significance. So if we look at studies that include low-risk patients, low rates of completion thyroidectomy, we can quote a number of 5% risk of recurrence. And when we counsel patients before surgery, we usually quote 5% risk of recurrence with slightly higher numbers in young patients, around 7 to 8%. And the risk of completion thyroidectomy based on the pathology report is around 10%. And again, this depends on how we decide to treat patients. So it can range between 10 and 40%, and we're going to discuss who are the patients who really need completion thyroidectomy. So let's start before surgery, and after that, we will discuss what happens after surgery and specifically the pathology report. So how do we choose the right patients for lobectomy? We all know this famous image from the ATA guidelines. The conservative approach is to do lobectomy for only this small group of people, but today we can increase the number of patients who undergo lobectomy. Many of these features are already in the 2015 guidelines. And for now, we can say that most patients can have lobectomy as treatment for thyroid cancer. So let's start with the lower end, the decision between active surveillance and lobectomy, and later we'll discuss what we do with larger tumors. In 2016, Brito and et al. And a group from the United States and Japan published, I think, a very good framework for how to think who needs active surveillance and who needs lobectomy. And they suggested looking at the nodule, at the patient, and at the medical team. Looking at the nodule, this is smaller than 1 centimeter. If it's surrounded by normal tissue, it would be ideal for follow-up. If it's below the capsule but no evidence of invasion, it would be appropriate. And if we see extrathyroidal extension, or it sits on the recurrent laryngeal nerve, or splashed on the trachea, then we will send them for an FNA and consider surgery. The best patients for active surveillance are patients older than 60 years old, because then if they have micro PTC, it usually stays stable. They need to be compliant and willing. Inappropriate are patients who are younger than 18 years old and are not non-compliant for follow-up. And in the middle, we have again an appropriate group. And the medical team, this is us, sometimes it's the most important factor. If we have experience with active surveillance, if we have quality ultrasound, it will be ideal. If we have partial experience, let's say one physician is very experienced and the other one doesn't believe in this approach, it's going to be challenging and an okay ultrasound, and it would be inappropriate if we have no experience or don't believe in this approach and no ultrasound, can't do proper ultrasound follow-up. Now, when we think about larger tumor, I think the same approach can be incorporated. So if we have a unilateral, let's say 2 centimeter PTC, surrounded by normal tissue, no suspicious lymph nodes, it would be ideal for lobectomy. If it is subcapsular, but we don't see gross extrathyroidal extension, we don't see on imaging extrathyroidal extension, it would be appropriate. And if we see extrathyroidal extension or lymph node metastasis on imaging before surgery, most of these patients will go to total thyroidectomy. Now, sometimes physicians, colleagues ask, okay, you have a 3.9 centimeter PTC in a 28-year-old patient. Would you do a lobectomy? So luckily for us, usually these patients don't really exist. Just another point, if they have a contralateral benign looking nodule and we did an FNA and it's benign, it shouldn't be an indication for total. So it's perfectly safe, there are several studies showing it, to do lobectomy in the presence of contralateral benign nodules. Now, when PTC, papillary thyroid carcinoma, increases in size, we find more extrathyroidal extension and more lymph node metastasis, and that's why most lobectomies are for tumors up to 2.5 or 3 centimeter in size, though there are some unusual cases of larger tumors. And the most important thing maybe in this context is quality ultrasound. So if you have someone and you refer someone for surgery and you know that the ultrasound they did before is not the best one, if you have an option, it would be prudent to do a quality ultrasound that in a substantial percentage of cases can change the extent of surgery if we find, for example, suspicious lymph nodes. And then we send a patient for surgery. Maybe we'll discuss later. During surgery, the surgeon has an important role because we can send someone for lobectomy. During surgery, the surgeon finds central neck lymph nodes or extrathyroidal extension towards the nerve, towards the trachea that we didn't see. So the intraoperative decision-making is very important, and we'll discuss it with Dr. Shaha. And then after surgery, we get the pathology report. And many times, the reaction is this. So before surgery, everything looked okay and quiet, and then we get the pathology report, and then we find there's a small lymph node or minimal thyroidal extension or tall cell variant or other what we call adverse histological features then that make us worried about the patients, and many times we raise the question whether they need completion thyroidectomy or not. So we'll discuss this topic for papillary thyroid carcinoma, and after that, shortly about follicular thyroid carcinoma. So after the 2015 ATA guidelines, there were several studies, including this is one of the best ones, that put into question whether lobectomy is a good idea. What they did, they took all their patients who had total thyroidectomy, looked back at their files, and used the ATA guidelines to see who would be appropriate for lobectomy. And then all these patients that would have been appropriate for lobectomy according to the ATA guidelines, they looked at their pathology report, and 43% of patients had what they called high-risk histological features, including minimized thyroid extension and tall cell variant and lymph node metastasis, etc. And their conclusion, there were a few other studies like that, and their conclusion was, okay, you can do a lobectomy, but just know that about half of your patients would require completion thyroidectomy. Now, if you think of it, it really doesn't make sense, because we started with saying that lobectomy is more than enough. Most patients don't need treatment at all. So how come when we look at the big picture, everyone is fine, you don't need to do screening, if you find them, then lobectomy is fine. But when you look under the microscope, you find all these high-risk histological features. It doesn't fit the approach that we use today. And to answer this question, we did a meta-analysis published in 2022, and we looked at autopsy studies. We looked at autopsy studies of people who didn't have a diagnosis of thyroid cancer during their lifetime. So this is the reservoir of people we were discussing at the beginning. There were a lot of subjects in these studies, more than 8,000. The prevalence of thyroid cancer was 8.5%. Most of them were microscopic, subclinical disease. And interestingly, these adverse features that we see on the pathology report existed also in these people, in these autopsies. Multifocality, 27%, minimal thyroidal extension, 18%, lymph node metastasis, around 10%, lymphovascular invasion, around 10%. So what this tells us, the message of this study, is these small features, as long as they are small in size, don't seem to be an indicator of an aggressive disease. Only when they are larger, when are more prominent, then they truly are risk factors for recurrence. So let's take a patient. So this is a 42-year-old female. She goes for a lobectomy, and the pathology report shows papillary thyroid carcinoma, 1.3 centimeter in size. So far, so good. Everyone's happy. Now let's take exactly the same patient. We would be very happy, all of us, to just continue follow-up. What happens if you add to this tumor any one of the following? So the same tumor with minimal extrathyroidal extension, the same tumor with multifocality or small lymph nodes or tall cell variant. Does each one of these features constitutes an indication for completion thyroidectomy? That's what we're gonna discuss now. And let's start with minimal extrathyroidal extension. And to go over the literature, you can find whatever you want. You can find that it has no clinical significance. You can find studies that shows increased risk of recurrence, and it really depends on the population, of the definition, whether or not they had lymph node involvement, whether or not they were treated with radioiodine. There are many, many factors to consider. But if we want to have a clean question, to have a clear question, this would be the question. We have a solitary thyroid carcinoma, not smaller than 4 centimeter, and plus or minus minimal extrathyroidal extension. It can be a difference of 1 or 2 millimeter in extension outside of the thyroid. So what's the meaning of this minimal extrathyroidal extension? And this is a study by Talia Cohen-Dicker from our team. And in patients with minimal extrathyroidal extension, we found risk of recurrence of 3.5% versus patients who had intrathyroidal PTC of 2.2%. And we can all agree there's no difference, clinically significant difference between these numbers, though the statistically it was significant. So some people also use this study to show it is significant, it's not significant, but we can agree that the difference in recurrence rate between 2.2% and 3.5% is not significant, and it's both of them are lower than 5%, which is the threshold for low-risk disease. There was very few data about lobectomy, so patients who had lobectomy with minimal extrathyroidal extension, the risk of recurrence was about 5 to 7%. And we've just sent for publication our study, our experience with patients who had lobectomy. We found minimal extrathyroidal extension, just continued follow-up, and in our institution, the risk of recurrence after more than 4 years was 3.2%. So we can say that minimal extrathyroidal extension, not seen on imaging before surgery, not seen by the surgeon, has little impact on the risk of recurrence. Next, multifocality. So in the ATA guidelines, 2015, multifocality was not a risk factor. It wasn't in table number 11 where low, intermediate, and high risk patients were defined. We can, when we think about multifocality, we should think about the minimal multifocality. So we have one dominant cancer foci, and then maybe 1 or 2 more foci, where it really doesn't make a difference in the risk of recurrence. But patients who have thyroid with numerous foci of thyroid cancer, these patients do have a higher risk of recurrence. And in recent years, these are studies from 2020 and 2023. There were 2 pretty large studies, sufficient follow-up, that showed that the risk of recurrence between patients who have lobectomy and total thyroidectomy is similar. If you look at the numbers, there may be 1 or 2% difference. It's not exactly the same. Look at the recurrence, contralateral, local regional, the whole recurrence group. It wasn't clinically significant, but probably there's a 1 or 2% risk difference between total thyroidectomy and lobectomy, but all these numbers are lower than 5% or close to 5%, and they shouldn't be an indication for completion thyroidectomy. Small metastatic lymph nodes, so the ATA guidelines did give an option for continued follow-up if you have just tiny lymph node metastasis. We know that central neck, level 6, tiny lymph nodes are very common. If you do a prophylactic central neck dissection, you would find tiny lymph nodes in about 30 to 50% of cases. There was a period of time when many surgeons would do a prophylactic central neck dissection, but most centers today abandoned this approach because the benefit was minimal to no benefit in low-risk patients, and there were more complications. These are some of the new studies about tiny lymph nodes in patients undergoing lobectomy, and again found that lobectomy is safe in patients with small volume N1A disease. So we agree with the ATA guidelines, just saying that the threshold of 0.2 centimeter is not really well established. We don't think there's a substantial difference between 2 millimeters and 3 millimeters. As long as the volume of disease is very small in the central neck or just adjacent to the thyroid, it shouldn't be an indication for completion thyroidectomy. Now, the last histological feature, which is the most, let's say, emotional, when we discuss whether this should be an indication for completion thyroidectomy or not. So first, the number of patients that we're gonna have with tall cell variant is going to increase, or already increased, because the WH classification decreased the threshold for tall cell variant from 50% to 30%. And these tumors typically present, and this is the most important word, present with more advanced age, more advanced T-score, higher rates of lymph node metastasis, and more extrathyroidal extension, and most of them harbor BRAF mutation. But what about if we find a small tumor limited to the thyroid with a tall cell variant? If we didn't have the chance or didn't behave aggressively, should we treat it aggressively as we would do with more advanced disease? And here we have two considerations. First, what is the risk of recurrence if we have a small intrathyroidal tall cell variant tumor? And second, if we go for completion thyroidectomy, the reason to do that is in order to treat with radioiodine. And we need to consider first what's the risk of recurrence, and second, what's the benefit from radioiodine in this group. So here we see a nomogram. This is from a recent study, and they looked only at tall cell variant and patients with tall cell features and quantify the risk associated with each feature of these patients. And you can see that just the presence of tall cell variant by itself is a pretty weak predictor of recurrence. The strong predictor of recurrence were involved margins, involved lymph nodes, and primary tumor above 1.5 centimeter. If it was below 1.5 centimeter, you see they get 0 points, because it seems that in their study, and we'll see additional data, in their study, if it's tall cell variant smaller than 1.5 centimeter, no other adverse feature, the risk of recurrence was low. In regards to radioiodine, there are multiple studies. It's a whole topic for a whole new session, but we do think that the response to radioiodine of tall cell variant tumors is lower than in classic papillary thyroid carcinoma, and we know that the benefit that we're going to get with completion thyroidectomy and radioiodine is lower than in other cancers. So if we look at cumulative data that we have to convince us that tall cell variant, as long as it's intrathyroidal and small, is not more dangerous than other studies, than other tumors, we have a 2018 study by Mingzhao Zing group. He has a very strong group studying BRAF mutation, and they showed that if you have patients with BRAF mutation, it wasn't specifically tall cell variant, but it includes patients with tall cell variant. If it's intrathyroidal, smaller than 2 centimeters, there was no increased risk of recurrence. Several studies, this is just the largest and latest one, showing that after total thyroidectomy, if we have tall cell variant tumors smaller than 1 centimeter, they behave similarly to classic PTC as long as they are intrathyroidal. And just recently, a study from Memorial Sloan Kettering, patients who had lobectomy, on pathology report they had tall cell variant, third of them had multifocal disease, and none of them had recurrence. So I think that as of today, we have enough evidence to say that if we have a solitary PTC with tall cell variant, with no adverse feature other than that, and smaller than 2 centimeters, these patients can be safely followed without completion thyroidectomy or radioiodine. So just to say what we discussed so far, adverse, in quotes, histological features are very common in PTC, and as long as they are minimal in size, they are not an indication for completion thyroidectomy. And using this approach, less than 10% of patients are expected to require completion thyroidectomy following the pathology report. Now, two last short topics. First, the follicular thyroid carcinoma. When we think about follicular thyroid carcinoma, the considerations are different. We look at the capsule of the tumor, invasion of the capsule, invasion of the vessels, vascular invasion. The WHO, these, by the way, almost all the time will have diagnostic lobectomy because they're going to have Bethesda 3 or 4 and RAS mutation on molecular markers. So according to the WH classifications, we have the minimally invasive tumors, and in this case, only capsular invasion, no vascular invasion. They can have lobectomy, and that's in the guidelines, and that's settled. If we have widely diseased, we obviously are going to treat it more aggressively. The challenge in these patients is the angio invasion, because we have several pitfalls. First, it depends on the extent of capsule processing. If you have a 5 centimeter follicular thyroid carcinoma and you do 10, you have only 10 slides, you can easily miss vascular invasion, and that's why in these cases you need whole capsule processing. The criteria for true angio invasion is somewhat controversial, and the guidelines are also not in agreement. We have the ATA and WHO guidelines and classification, and they look at focal angio invasion less than 4 foci of vascular invasion or more than 4 foci. But the European guidelines, German, British, the endocrine surgeons, they recommend that all angio-invasive FTC should have total thyroidectomy. A recent study by Azamaki, I think it was a very well performed, more than 250 patients, all of them with angio-invasive follicular carcinoma. It's from the Ito hospital, and they showed that patients with 2 or more vascular angio invasion foci are at risk for distant metastasis, especially with age over 55 and with larger tumor. So I think that with follicular carcinoma, we need to be more careful, because if we miss something in papillary thyroid carcinoma, we're going to see lymph node metastasis or thyroid bed nodules, but it is treatable. If we miss something in follicular thyroid carcinoma, we can miss distant metastasis. So I think this needs careful attention and discussion with the pathologist. Last let's discuss this TSH target. The ATA guidelines recommended to keep patients after lobectomy with a TSH lower than 2 milliunits per liter, and it was based on expert opinion. There was really no good data on this topic. And in 2022, a huge study, more than 2,000 patients who had lobectomy, and they analyzed the risk of recurrence as correlated with TSH levels. On the left side, you can find the whole cohort. There was some correlation, but on the right, you can see low-risk patients. With increasing TSH, there was no association with risk with disease recurrence, and we can say that we have good data to show that after lobectomy, TSH in the normal range is recommended, and that would decrease the need for therapy from around 70% to around 30 to 40%. And for the quality of life of our patient, it is very important. In terms of thyroglobulin levels, there was a suggestion to use 30 nanograms per ml threshold for excellent response or indeterminate response. But since then, there were multiple studies that showed there is no correlation after lobectomy between thyroglobulin levels and trends. And they also showed that after lobectomy, many times, thyroglobulin levels increase over time, maybe demonstrating hyperplasia of the remaining lobe. So thyroglobulin can be used just to see, there's not as a surprise, that to see thyroglobulin is not 1,000 or 800. The vast majority of patients will have thyroglobulin lower than 100. In our institution, if there's a patient with a very high level of thyroglobulin, we would send them for imaging just to be on the safe side. You can also consider completion thyroidectomy because it would be very unusual. But we can say that the follow-up is based not on blood tests, but rather on neck ultrasound. So in conclusion, lobectomy is the preferable surgery for most patients, suitable for low and what we will call in the next guidelines, low intermediate risk patients, TSH target within the normal range, and follow-up is based on ultrasound. The future, what we need to do next, we have quite a lot of work left to be done. First, we need to know who needs surgery at all. We said at the beginning, most patients probably don't need surgery, can be followed, but we still don't have tools good enough. We use the 1 centimeter threshold, but we want more accurate and biological markers to see who would grow and which tumors would grow and which will not, and who will respond to radioiodine, because the reason we do completion thyroidectomy almost always is in order to give radioiodine, we need to have better understanding when to give radioiodine and when not to. Thank you for listening, and we'll have a discussion with Dr. Shaha and Mark Urken. Thank you all.
Thank you. Really spectacular. It's an article that all patients treating thyroid cancer should read and reread. We've got a number of questions from the audience, but Ashok, I'm going to give you, and I've got my own set of questions. We are going to extend this for the next 3 hours. I hope everybody is available to can cancel all of your other obligations here. But certainly something we will have to come back to. Ashok, why don't you start off the discussion?
Yeah, I'll take a very short time because we have a lot of questions coming in. I must say, Eyal, we enjoyed your presentation. It was thoughtful, state-of-the-art, and trying to resolve the controversy which is going on almost 50 years around the world. What I want to say is, even though the controversy has been there for 50 years, the memorial has not changed the philosophy.
Yeah.
We always strongly believed in all the aspects of thyroid surgery that you mentioned, the complications, the recurrence, etc. The one point we need to resolve is when we talk about the recurrence after lobectomy, quite often it's a recurrence in the opposite lobe, which is a normality. We know that 5% of the people will have thyroid cancer. So that group would need surgery, not because of the cancer on one side, or we did lobectomy or anything else, but they will need completion thyroidectomy if you follow them very critically. The quality of life is very critical. Just, Eyal mentioned about 25-year-old girl. She's my daughter. She has 75 years to live rest of her life. She's going to become pregnant. She's going to breastfeed the baby. Trying to live with total thyroidectomy and thyroid medication is not as easy as it is portrayed. People say it is not a big deal. Take one pill in the morning. No, it's the same analogy as a diabetes. The patient with diabetes lives normal life, but the quality of life changes quite a bit. Can't eat cake on his own birthday. Remember that. So I'm just throwing this as a thought process when we consider surgery. The one thing we need to realize is the whole idea of completion thyroidectomy or risk group analysis was to see who would be benefited by radioactive iodine. And we have shown again and again, and the new ATA guidelines have shown that the routine use of radioactive iodine is not going to help the patients. So I think this is something that we need to keep in mind. The responsibility dwells on the surgeon to do a good preoperative evaluation and make a critical decision in the operating room. We're not going to debate about central compartment dissection because we're always going to evaluate it. If there's anything abnormal, I'm going to take it out. I'm not going to leave it behind. I'm going to look on both sides. This is the debate going on. But remember, 80% of the patients will have microscopic disease, which will have no impact on the long-term outcome. We keep debating about lobectomy versus total thyroidectomy. We don't debate in larynx cancer, total laryngectomy or partial laryngectomy. We don't debate in stomach. We don't debate in colon. The risk of recurrence is 10%. Why do we debate in thyroid only? You know why? There is a reason behind it. Our background, our training, our philosophy, our institutional practice, and most important, the surgical prejudice or surgical ego. Thanks, Mark. Go ahead.
Very good. I want to get to these questions. I just want to ask one thing, Eyal. We have one of the critical questions that always comes up is related to the findings in the opposite lobe in a patient who we otherwise think is a great candidate for a lobectomy. And we have certain guidelines for what should be biopsied and what we should just observe. But it becomes more critical in that preoperative period when you're trying to make an informed decision. So what is your threshold for biopsying something in the opposite lobe to give that patient reassurance that they're making the right decision to perform a lobectomy?
So I think there's a difference between the theoretical approach and the practical approach. Because theoretically, I think if someone doesn't need radioiodine, we can look at each side individually. And if there's no indication to touch the other side, we shouldn't touch the other side. In reality, surgeons don't want to go into surgery and leave behind a 7mm PTC on the other side that you see on each ultrasound. And each time they're going to do an ultrasound, they're going to get a TRAS-5 for a suspicious lesion. So usually, if we have something suspicious on the other side, even if it's small, even if it's smaller than 1 centimeter, well, we sometimes do an FNA and take this lobe out. I'm not sure we have the data to support this approach. I think it's a mixture of, expectations and medical legal considerations and the patient's need to feel cured after surgery. So I think we have many other considerations. We usually are more aggressive in assessing the contralateral side. But again, if there's nothing suspicious there, if there's a low risk nodule and it's benign on FNA, we don't touch it.
Great. Ashok, do you agree?
I think he well said, extremely well put and well said. If the nodule is below 5 millimeter, we don't do anything. Simple.
Yeah.
5 to 10 millimeter, easy to biopsy, radiologically suspicious, I'll do the biopsy, and more important, to explain the patient and the family that you have tiny nodule on the other side. We'll do the biopsy. If it is cancer, I'll take it out. If it is not cancer, we'll discuss and we'll monitor you. And I think Eyal said it very well. You don't want it to happen that 1 year from today, somebody does a completion thyroidectomy and there is a 5 millimeter cancer. It doesn't make any difference outcome-wise, but emotionally, patients get disturbed. Remember, the management of thyroid cancer is not just the outcome, not just the long-term survival, but the emotions of the patient. And we need to analyze the patient. Is he a minimalist or maximalist?
So to that extent, I will say I've noticed, and it's a small cohort of patients who were minimalists in terms of accepting active surveillance for low-risk disease.
Yeah.
When they had progression and went to surgery and had a lobectomy and were found to have adverse features, their mindset changed to becoming a maximalist. And it's an interesting transition and one that is psychologically very challenging. But in the interest of time, I do want to get to some of these questions. I don't know if we're going to get to all of them, but the first one is from Courtney. I'm very much an advocate for expanding use of lobectomy, but very worried about all the studies are massively underpowered and subject to type M and type S errors. If you have 1,000 patients plus a 5% event rate and a fairly standard 50% non-administrative censoring rate for observational studies, that means your effective sample size equals 25, which is far too small to get stable estimates. It's a complicated question. Eyal, do you want to tackle that?
I want to give Ashok the stage because Memorial has been doing it for how long? 50 years? How
Yes.
long, Ashok?
Yes, 50 years, more than 50 years.
Yeah.
And again, I think, all these data analysis, etc. And that's why I use the analysis of analogy of my daughter, 25 years old. I think you can always do completion thyroidectomy if necessary. But the value of maintaining good thyroid function and the quality of life is critical. And I'm very convinced that unless there are very, very aggressive features, not the intermediate risk that we described, there is hardly any reason to do completion thyroidectomy or total thyroidectomy at the time of surgery.
Just to add one point, if you have a patient with Hashimoto's thyroiditis and the completion thyroidectomy is going to end up with a vocal cord paralysis, let's think about a theoretical case. It's better to have this vocal cord paralysis in 20 years and not now. If they're going to have hypothyroidism, it's better to have it in 10 years and not now. So the answer is not black and white now. We can also think about the life course of the patients.
Well
Great.
said.
Yes, agree with that. Gosh, there's two comments I will bring up. Kate Newbold from London does highlight that there's a randomized control study going on across 32 centers in the UK looking at hemi versus total thyroidectomy. So hopefully we will get some insight from that. And there is a recent study that Dr. Tunisia highlights that came out from Japan, looking at doing lobectomy in patients who had N1B disease. Quite an aggressive approach to doing more limited surgery, showing the safety and the non-inferiority of doing a lobectomy. Eyal, do you want to give us your final word on, are we extending the boundaries too far here?
No, I think we're extending the boundaries too little. I think many of the patients who undergo lobectomy in 10 or 20 years will not have surgery at all. We just don't know how to select them as of today.
Terrific. Listen,
We have a
I
study
want to,
coming out with a lobectomy and neck dissection for lateral neck nodes with no survival difference. The Japanese have been doing it for the last many years, but we have started this and we have data that will come out in the next few months.
awesome. Looking forward to that. Thank you both. Thank you for your insights, your experience, and thank you to our listeners. I apologize to those who I could not answer their questions. Eyal, I don't know if you have a minute just to perhaps type answers to those questions, but thank you all. Look forward to seeing you again next week.